One of the world's most important and common inflammatory diseases is gout. Yet, as we all know, it's a condition about which jokes are frequently made. We're fortunate to have with us Professor Mandell, who has been speaking here on the clinical importance of gout today. Professor, could you begin by telling us, why is gout a serious medical condition?
Well, I think you're spot on with your introduction that it's the butt should be the foot of much humor. I think historically, because it was viewed as the rich and the well-to-do who are always prime targets to be made fun of. But you're also spot on in that it is the most common form of inflammatory joint disease or arthritis that affects patients today, and this is worldwide. And it travels with a series of comorbidities related to the underlying biology, physiology, if you will, of having high levels of urate. So gout is associated with chronic kidney disease, with coronary disease, with heart failure, with hypertension, fatty liver, obstructive sleep apnea, many very strong associations. The symptom, the red swollen toe, the knee, the wrist, this is a symptom of the disease. It is not the disease. The disease of gout is really the deposition of uric acid over years. And then to the point that you have enough deposition of uric acid in and around joints that these deposits of urate crystals just break forth and cause the attacks of gout, and that gets people's attention. And I think sometimes we as physicians need to just remember that it's the disease of the deposition that needs to be addressed, not just the symptom of a flare. So even in between attacks, the disease is still there unless we've done something to address it.
And how should the primary care physician treat it?
Well, the first step is really to be confident in the diagnosis. The actual diagnosis should be made by a synovial fluid analysis seeing the gout crystals, which I understand many, if not most, primary care providers neither have the inclination to do and probably not the time to do. So you may need some assistance from a rheumatology colleague, an orthopedic colleague, or maybe an interventional radiology colleague to get fluid to make the firm diagnosis. But you want first to be accurate in your diagnosis, because to treat the disease effectively will mean that you need to lower the urate level to below that saturation point of urate, which is really below, I would say, a reasonable target, a level of 6 milligrams per deciliter, which means taking lifelong therapy. When should it be treated? And depends on the individual. A 90-year-old who has had one attack of gout, maybe they don't need lifelong urate-lowering therapy. Maybe they just need their attack addressed. A 25-year-old with a family history of gout and a brother, father, and an uncle, that patient probably needs aggressive urate-lowering therapy. So the primary care physician needs to individualize, but I think the low point, at least in thinking, the low bar, is saying a patient who has gout, and I'm positive of the diagnosis, why should this patient not be treated in a way that will prevent attacks in the future and ultimately really cure the disease, which is the deposition of the urate which causes the attacks?
And what is the current status of therapies for gout?
And we have to divide between therapies to treat the symptom, treat the flares, and to treat the underlying disease. To treat the symptom of flare, this is actually relatively easy with many options, although the comorbidities of a patient may influence our ability to use some of them. But the non-steroidal drugs, low doses of colchicine, corticosteroids, and more recently, if you have it available, the interleukin-1 antagonists are dramatically effective at shortening and resolving attacks of gout. The urate-lowering therapies, to get that level of circulating urate down below 6 to a level where the deposits, instead of going from the blood into the joint, will go the other way and dissolve into the blood, this has been a little bit more of a challenge. Allopurinol has been the go-to drug for decades, and in many countries still is the only drug that is available. There is an alternative xanthine oxidase inhibitor. Xanthine oxidase is the rate-limiting enzyme for the generation of uric acid in the body in humans. Allopurinol inhibits that. Febuxostat, if that's available in your country, is another option to do the same thing. And if you manage the drugs correctly, which means increasing the dose to the level that gets that serum urate down to your target level, these are effective medications. The problem is we as physicians don't use them effectively.
In summary, how hopeful are you about improved management of gout in the future?
Modestly hopeful. Of course, everyone who has seen this interview will change their practices immediately.
Professor, thank you very much indeed.